Thank you all for a great panel session. I have a couple questions, so I'll try to be quick. Thinking about excitatory inhibitory, you also kind of set the stage thinking about the fact that GRIN2B genes are maybe the expression is early development. So I'm curious your thoughts about the developmental trajectories of excitatory inhibitory balance or imbalance. And if you think that that's stable, I think the 5 kids for the GRIN2B simple were quite young. I can't remember what the oldest, how old the oldest was, but if you could just talk about your, even kind of your expectations about the developmental considerations for EI imbalance.
Well, it's a very good question in terms also of the natural history. The honest answer is we have far too few experience to really know how it evolves. So it might well be that, for instance, in more older children, the sign of the ratios change or become less inhibition dominated spontaneously, or that depends on the epilepsy phenotype. So we have completely no idea. This was just very crude first interpretation that in these age ranges, especially if they're more severely affected, that we found these type of results. But indeed, it's very important to study the natural history of the EI balance, so to speak. But we just don't know yet. For GRIN2B then, huh?
Yeah, and I think that the other part that keeps coming back is your work is just so thorough, which is so fantastic to have all of those pieces connected. I think having that kind of application that you're describing, where you really are for each child able to kind of bridge in those pieces, I think is going to be absolutely critical. And kind of understanding, I think puberty is the place that always gets me, because so many different biological things are happening during puberty, and our GRIN kids also have atypical onset of puberty sometimes. So kind of understanding these biological pieces is going to be really, really important.
Yeah. For instance, there are two important natural shifts. First, the chloride shift, and then later on the glutamate shift, so to speak, that could occur very differently in GRIN2B children, for instance, that we have not studied. So all that type of factors should be taken into account, definitely. Yeah.
One other quick question for you. So I really appreciated you using the ICF model to kind of think through how individual circumstances really need to be considered. I'm curious if you have perspectives on the parents' role in that context. Because as you were talking even early on, I was just thinking, oh my goodness, for our parents that have a child with intellectual disabilities or challenging problematic behaviors broadly, or emotion dysregulation, things like that, parents' mental health also can suffer and be a sticking point. So I'm curious if you have any kind of thoughts or perspectives on how parents also need to take care of themselves or manage themselves in order to help provide support for their child.
Yeah, thank you for your question. I'm a strong believer in the health condition of the parents. Also, their emotional condition is crucial for the child to develop, of course, within the limits there are, obviously. But over the past year, I'm so worried a little bit too, that parents, when they get the diagnosis after a whole trajectory of so many examinations and all that, and then there is this diagnosis, and then they're lost in translation, because then all of a sudden they have a genetic condition. Well, it may be, of course, this is very black and white, but they hear this is the condition, there is nothing we can do really, have a good life. And once they come back, then they can look at it from a perspective of a developmental disorder, of intellectual disability or whatever, and not just a genetic problem there is nothing you can do about. And I believe that if you just keep on walking with these parents and have psychoeducation from the first start off, they so much better get to know their child. And that is so important in terms of frustration, burden, all those sorts of things. So I believe, parent, and also they can sort of, the situation in the family and also the parent's health condition can in fact influence the outcome of the children. clearly. So really important, I believe.
Hi, thank you so much. I have a question for Dr. Dominguez on epilepsy, and I want to ask you if there is an age or a specific moment in link, for example, to a development of the kid when epilepsy can appear. Like a kid can not have epilepsy when he's 5, but maybe at a specific moment it can appear. Is there any kind of age or?
Well, what is described until now is that most of these patients have epilepsies starting in the pediatric age. In the GRIN 2D, that is called epileptic encephalopathy, are set to start in the first 1 or 2 years of life, and in the others around in the first decade. But probably those patients that have not experienced yet epilepsy could experience them in any other moment of their lives. I think we don't have, as we said, enough information, natural history, prolonged or long information in adults. So I cannot answer that question properly. It can appear in any moment, at any moment. It's not something that starts at exactly one age, and then if we have passed that, we are relaxed. But well, what is described is that there is something happening usually in the first decade of life.
I have questions. Oh, I have questions about why this is so loud. I have questions across the board, so please bear with me. I want to start with Dr. Bruining about when you talk about precision medicine. One of the things that we've seen the most thus far is ASO therapies, which up to present, at least, the specialists that I've spoke to, I've talked about the difficulties of developing an ASO therapy for something like GRIN 2B, but yet I saw it in one of your slides. Do you believe that there's potential there, or is that just trying to be like a catch-all of N of 1 therapies?
You mean whether it can be developed for this specific context, or it will be more generic approach, you mean?
Right. So when you were talking about precision medicine, I saw, you talked about drug repurposing and obviously inclusive of ASO therapies or genetic therapies. But I haven't yet seen other specialists that think that ASOs are really something that are potential for GRIN 2B. Do you feel differently?
Yeah. So if you look at the broader field of genetic disease-altering therapies, there's an enormous development of it. It's for some. Indeed, for maybe not so much for GRINs yet, but for some others. So the techniques some elements are generic in their application and what you need to develop them and how to bring them about. I think it's also a bit of luck that you need some biotechs that really start participating in this specific field. I think showing unity in your natural history approaches and in your science in general will make that happen more fastly. And I think, technically speaking, some of the disorders which are attempted now, like STXBP1 or CDLK5. What I understand, but maybe you can answer better, that molecularly speaking, they're more difficult and more challenging than GRIN 2B in theory. So it should be feasible, but you need to find to lure some parties into your game. Yeah.
Fair enough.
Yeah.
And then Dr. Oostrom, with regards to the therapies that we can provide our children to meet that gap while we await for these treatments and cures, are there any that you've come across? There's obviously the standard physical and occupational therapy, but we've also see things like DMI, pivotal response therapy. Have you had any experiences with those, and what are your thoughts?
Yes, we do, because of course we have those broad, what's that called? Dashboards of our children, get the information from everywhere. And most of the children, they do get some sort of therapy, also therapies that you call upon now. But I am not sure whether those therapies are based from, are indicated from this sort of information processing perspective. And if you think from that context, you may put those therapies on a different moment in time or a little bit tweaked to a particular situation. And so far now, they've just been put on whatever, just try to do anything. And if you do that more tweaked and more personalized too, like we like to do everything more personalized and precise, I think we need to make shifts and progress in that field too.
Fair enough, thank you. And then lastly, Dr. Dominguez, with regard to the seizure onset or seizure prevalence, I should say, in GRIN 2B, I saw that it said 50%. I've seen other numbers that say it's actually lower. Is that specific to maybe a Spanish cohort, or is that just your personal patients?
No, that comes from the literature, and probably this is something that is changing day by day. So probably the numbers are not so accurate.
Fair enough. Is there a particular seizure type that you've seen more common in GRIN 2B patients?
No, I think that what is described is a really broad spectrum of seizure types, and that usually they change. And this is also something that is quite typical in other epilepsies due to gene disorders. So, well, it's something quite typical in genetic epilepsies, that seizures change from one to another. Well, tonic seizures, epileptic spasms by one age. Well, they are changing over time.
Fair enough. Thank you guys for your answers.
But do you think that seizures beget seizures, that they sort of inflict another, or is it still
if seizures
that seizure type developed and sequentially sort of evolve?
Well, I think this is something that we see sometimes because of it depends on which part of the brain is having that excessive activity in by different moments, and sometimes because of the developmental of brain. Because, for example, for epileptic spasms, is something that it has been said to only occur in the first year or 2 years of life, so in mature brain. But nowadays it's more than known that they can appear in any moment of life. But when we see in older children, in children aged 4, 10, well, I only see until 18, usually what in my experience, they have focal epileptic spasms, and they are usually related to malformations, to usually cortical brain malformation. So again, a brain that is immature, at least in that part of the brain. So probably something related to brain development or to brain maturity, that seizures change their appearance from one moment to another.
Or is it possible that the sequence of different seizures and seizure types is caused by medication, or that one seizure causes the other, and that they're actually unrelated to the inaugural event?
Probably there are lots of things that happen and that can participate in some way in how seizures look like. Yeah, probably.
May I have a question to Jana? May I have a question? My understanding is that for GRIN 2A mutations, epilepsy is a common sign, and in many cases, this epilepsy combines with aphasia, dysphasia, or language problems. For some epilepsies, they vanish when the child reaches adulthood. I wonder whether the dysphasia or aphasia also vanishes when they reach. And this has a related question. When you treat these patients by anti-epileptics, do you also improve speech problems?
Well, epileptic encephalopathy with spike and wave activation during sleep is really a specific form of epilepsy. What I have seen related, or what I have seen in GRIN 2A related disorders, I think these so-called speech problems and epilepsy is not exactly a good name, because there are some children that do have self-limited epilepsies without speech problems, without any intellectual disability or any neurodevelopmental disorder, like what we used to call Rolandic epilepsy, that we don't call that like that. And speech problems appear in a small proportion of patients that have this Landau-Kleffner syndrome. In other children with epileptic encephalopathy with spike and wave activation, well, what happens in Landau-Kleffner is that we have that continuous pattern during sleep, usually in the left temporal lobe, which is the part of the brain with which we speak or with which understand language. And when we have a more broad pattern of activation during sleep, a more generalized spike and wave activation during sleep pattern, usually what we see is a more broad spectrum of disabilities or of decline, without that specific pattern of aphasia. These children do not have an aphasia. What we see there is they have a specific. They are affected more specifically in executive functions, and they have really important problems for learning because of in terms of attention and planification and all these things. What we see when we get to manage or when we get to stop that pattern is that they improve, but there are sequelae. They don't get to their previous state. And in Landau-Kleffner syndrome, the sequelae should be or tends to be really, really important. These are children with a really important disability when the epilepsy disappears, but not the sequelae.
So I have one question, and I have a lot of them, but I have one question in particular. So the gelectric seizures that you see in some of the patients, was that related to the GRIN 2B cohort?
No.
No. Okay, because so when they do present, as shown in the video, do they ever present in sleep? So do some of the kids have? So when it's never presented in sleep.
They can appear during sleep, but they can appear during the day. There, well, I have brought that examples because I know that these behavioral changes, including laughs, panic, or crying, sometimes we don't know what are they happening, and sometimes you think, oh, could this be a seizure? Gelastic seizures are really, really, really rare, and they are mostly ever related to hamartoma, hypothalamic hamartoma, which is a brain tumor in a part of the brain called hypothalamus. And these are really rare. And when they appear, they are really strange. They are quite easy to recognize because, well, it's something that they look exactly the same every time the kids do them. And they are, well, really strange, really weird.
And the reason for me asking is because we know a lot of GRIN kids who have these like laughing spells, and they could just start laughing without like any apparent reason, and that would be like hysterical laughing. So I was just wondering whether there is any seizure related activity there. But thank you.
One more question.
Hi there. Sorry, we're still on the epilepsy here. How is treatment evolving at the moment, and where is it heading? Is it very different for every type of seizures, etc.?
Well, as far as I know, but probably I'm not the best person to answer this, there are no specific treatments for epilepsy in these children. I don't know if any of you have any other experience, but in my experience, there's no drug that goes better than others, and there's no, well, I suppose, I think these NMDA drugs, well, when we get to this, to know the physiopathology, it was like, whoa, we know what we need to use, but it doesn't work better than other things. So there's, I think.
One interesting thing will be, for instance, if like the PALMs or L-serine or bumetanide, whether they will enforce or weaken the effects of antiepileptic drugs and or seizure susceptibility per se. We don't know that. And I think therefore tracking things like quantitative EEG are important between seizures as well, because they obviously are a continuum. Yeah. Yeah.
I got a few online questions. Two for you, Dr. Bruining. First one is, I think it relates to the L-serine trials that you have, because a mom from UK asking where she can get L-serine, and does it need to be a special type of L-serine?
Very good question. So we have had quite some problems with that, because there are different forms out there, and the ones that we now are allowed to use is the most pure one, which is very expensive, and we need, I think, around 20,000 euros per 6 months trial per patient. Yeah, but there are also other forms, and also the other serines are testable, and I think actually Clara van Karneweg, she did write or is going to write a whole story about how that evolved, because it's a little bit tricky who's creating the protection on the type of the availability. So that's typically something with a community like this that we should address, and to make sure it is available once there is certain certainty that it has effects, because it's just a feeding supplement that should not be so expensive. Yeah, in my view, but yeah.
So basically, we don't have an answer quite yet out in the open.
No, but we need to keep an eye on the people raising the price. Let's put it that way. Yeah.
And the second one is from Alan to you as well. It's been reported that several families of GRIN 2B children with psychiatric symptoms, him included, multiple fails with AP and neuroleptic, and even more interesting and temporary expected effect disappearing within a few months. Could this be explained by a brain reaction to excitation inhibition balance modification?
So what was the initial part, sorry?
He's several families with children with psychiatric symptoms multiple failed with attempts with AP and neuroleptics.
Yeah.
And even more interesting, a temporary expected effect disappearing within few months.
Yeah, that's what we sort of also with the colloquialism of the best possible treatment. So the standard treatment, antipsychotics, but some children also receive stimulants, and both of them are known to reduce, for instance, seizures threshold, and also can have paradoxical effects. And one reason could be that we think that serious genetic disorders like GRIN 2B or GRIN create these immature circuits that have depolarizing GABA activity instead of hyperpolarizing GABA activity. And that's something that is indicative of bumetanide response. But in general, it's very important to know that and to understand whether that's also related to the EEG findings that we have, because if so, then it could be a relative contraindication to use that type of drugs.